That arch over the top of the shoulder can be hooked. It can have a hook on the front of it, which decreases the amount of space that the rotator cuff has. You can also get bone spurs that develop off of that from chronic inflammation that can push on it, and you can get AC arthritis that can push on the rotator cuff and cause bursitis and tendonitis in that area. And AC arthritis stands for acromioclavicular, so that small joint between the acromion and the clavicle can get arthritic, and you can get bone spurs from that joint that are pushing on the bursa and the rotator cuff, causing this problem. So that's what I look for on x-rays. With MRI, you can see tendonitis, you can see inflammation in the tendon, you can see fluid on top of the rotator cuff, which is the bursitis, and you can see an osteochromiale. What that is the acromion bone. Sometimes the growth plate that divides that bone in half doesn't fuse, and you can get a mobile portion of the acromion, and that can become painful and present as this impingement syndrome, rotator cuff tendonitis, bursitis problem. So that's what I look for on MRI. The typical treatment is anti-inflammatories or NSAIDs first, rest and ice. If that doesn't work, it's plus minus on physical therapy. Sometimes physical therapy will actually exacerbate this and make it worse. Unless the patient has a really scapular stabilizing problem where their shoulder blade is moving around too much, therapy typically doesn't help with impingement all that much. And then if all else fails, we go to arthroscopy, which is the scope, where I can clean out the inflammation on top of the rotator cuff, take the inflamed bursal tissue out, and smooth out the underside of the acromion bone to give the rotator cuff more room. And that typically, patients typically do very well and have a very quick recovery from a surgery like that. But most of the time, 70% of the time, this gets better without surgery, just with conservative management with the anti-inflammatories plus or minus physical therapy. If the patient does go to surgery, you can typically expect to be back to work very shortly, like as soon as you're off of the pain medication, within days to a couple weeks, to get a return to work as a desk job. But a labor job typically takes 4 to 6 weeks, because you want to get all the inflammation calmed down and get the strength back so you can lift overhead and do the physical demands of the job. 50% of the time, patients require physical therapy after this procedure just to get the range of motion back. And a full function is usually expected in about 3 months. A variant of this is calcific rotator cuff tendonitis. And this usually occurs in people who work with their arms up all the time. It's very common in hairdressers. Almost everyone I've seen has been a hairdresser. And it can also occur in dialysis patients because of the leaching out of the calcium. On their physical exam, it's the same thing. They have the impingement signs, and they may have weakness on testing of their rotator cuff strength. On x-rays, you actually see it. So you can see the calcium deposit right here in the rotator cuff on an x-ray. And you will also, if you have a good radiologist, they'll be able to pick it up on the MRI as well. But the rotator cuff will be intact, everything else will look normal, but they'll have this deposition of calcium in their rotator cuff. Typical treatment, if it doesn't get better with rest and anti-inflammatories, surgery for this is very rewarding. You do this through the scope, and then we take a spinal needle through the scope and poke the tendon. You'll see a little white speckle on the tendon. If you poke it, all of a sudden it looks like toothpaste shoots out. It's a pretty soft calcium deposit, and we can evacuate that with the scope, and the patients get immediate relief. So it's a lot of fun to take care of that, because they're happy right away. And I'm just like everybody else. I have no patience, so I want everybody to be happy immediately. And so it's a very rewarding thing. And those patients typically go back to work almost right away. And once the inflammation settles down, the cuff, it can get really bad. So that actually the rotator cuff gets pretty beat up, just getting all the calcium out of it, and it can take time for that to heal itself back over. And sometimes it's so bad we actually have to repair the rotator cuff after we take all the calcium out of it. And it can recur. If the underlying etiology doesn't change, there can be up to a 20% recurrence rate for the calcific rotator cuff tendonitis. So it's important to change lifestyle and behavior to prevent that from recurring. Another very common thing that often is confused with rotator cuff problems is proximal biceps tendonitis. A lot of times the biceps tendon, there's two heads of it, one of them actually goes up into the shoulder, can become very painful, and this is typically with or without trauma, and the patients experience pain reaching behind them or reaching across their body because they've developed a lot of inflammation in the biceps tendon or a tear in the biceps tendon. There's two tests that we do called the Speeds and the Jurgensen's test and a cross-body adduction test to look for proximal biceps tendonitis. So you can actually feel your biceps tendon if you push in the front of your shoulder and roll your finger over it. You may feel a small, it's about a 2 or 3 millimeter wide cord right there that you'll be able to roll over. And the patient will be very sore to palpation right there. And then the Speeds test is if you put your hand forward with your thumb up and try to push down, they have a lot of pain. Whereas if you turn your hand in or turn your thumb down, they don't have as much pain. But if they do have pain there, it's more likely the supraspinatus tendon or a rotator cuff problem and not a biceps problem. And then the Jurgensen's test is where you just have somebody push up against you like this, and they'll get pain in their anterior aspect of their shoulder because it's stressing the biceps tendon. The cross-body adduction test is simply bringing the arm across the body. The biceps tendon gets pinched in the front of the shoulder and will hurt if there's inflammation there. The x-rays are typically normal, and the MRI usually will show some fluid around the biceps tendon or inflammation around the biceps tendon. The treatment is the same. The algorithm, we're not very complicated as orthopedic surgeons. So if we can't treat it with Advil, a cortisone shot, or surgery, we don't know what to do because that's usually our algorithm for everything. So the first treatment is rest and anti-inflammatories. You can get a cortisone shot in the biceps sheath, and then we try arthroscopy after that. And there's two ways of treating that. You can either cut the tendon if it's very frayed, it's an older patient or a very heavy patient where you're not worried about a cosmetic deformity, then we would just simply cut the tendon. And you lose less than 10% of strength. It's not a functional problem, and it's also one of those rewarding things because patients typically feel better almost immediately. There's another surgery called a tenodesis where we can, after we cut the tendon, we can then sew it or anchor it into the bone, into the humerus bone, not onto the top of the socket where it normally attaches. And that we do that more for cosmesis than anything else, just so that the tendon doesn't retract in the arm and you don't get a Popeye muscle deformity. If you look at professional bodybuilders, they cut theirs on purpose because it gives them the peak of their biceps, so they all look like Popeye. But most patients don't like that or don't want it asymmetrically, so we would do the biceps tenodesis because of that. Typically after this, patients get their motion back in 2 weeks, can return to work for a desk job in about 2 weeks, and I expect the labor job to take a month or two. Rotator cuff tears, this is a big one. This is very, very common, where the tendon can actually tear all the way off the bone. It's usually atraumatic, and it occurs because within a centimeter and a half from the insertion of the tendon on the bone, there's a watershed area to the blood supply. So the blood vessels peter out in that area, and it doesn't get a good nourishment from the blood supply. Plus, that area is getting banged into the acromion all the time. So it wears out and it tears. And typically, it does not have to be a fall or a big trauma. It can just tear with degeneration in time. And patients typically complain of weakness with overhead activities, pain obviously, and trouble initiating shoulder motion. Because that's really what the cuff does. It gets you going. It gets it started. And once you get going, then the deltoid can take over. On physical exam, they have these impingement tests. They have weakness, and they have something called the drop arm test. So a patient with a large rotator cuff tear, they can get their arm up, and then you ask them to lower it slowly, and they'll get to the